Muy buenos días. Soy la doctora María de la Luz Ruiz, endocrinóloga pediatra de la Ciudad de México. El día de hoy tengo el honor de presentar a ustedes a la doctora Débora Merck. La doctora Débora Merck es investigadora principal y jefe del servicio de pediatría de los Institutos Nacionales de Salud en Bethesda, Maryland, y es considerada una experta en la hiperplasia suprarrenal congénita en todo el mundo. Sus investigaciones se centran en la fisiopatología y la genética de la hiperplasia suprarrenal congénita, que incluye el estudio del síndrome de lesión de genes contiguos denominados CAHX, que afecta aproximadamente al 10% de los pacientes con hiperplasia. La doctora Merck fue la primera de identificar la deficiencia de adrenalina como un nuevo desequilibrio hormonal en hiperplasia suprarrenal congénita. Actualmente, la doctora Merck realiza un estudio de la historia natural de los pacientes con hiperplasia y tiene más de 450 pacientes incluidos. Un aspecto fundamental en el trabajo es la investigación de nuevos tratamientos que incluyen terapias ayudantes de reemplazo del cortisol circadiano para permitir el tratamiento con dosis más bajas de glucocorticoides. Por lo tanto, los estudios de la doctora Merck brindan información sobre las complejidades del tratamiento y permiten y prometen mejorar el tratamiento de nuestros pacientes. El día de hoy, la doctora Merck nos hablará sobre las implicaciones de la terapia de reemplazo en la pubertad y en la talla adulta de los pacientes con hiperplasia suprarrenal congénita. Welcome, Dr. Deborah Merck, and thank you very much for sharing your experience with us. Bienvenida, doctora Merck. Muchas gracias. Adelante.
Thank you, Dr. Belgorowski and the Latin American Society for Pediatric Endocrinology for the opportunity to be here today. I hope all are well and that in the near future we will meet in person. Today, I will be talking about the implications of hormonal replacement therapy during childhood in patients with CAH with a focus on 21-hydroxylase deficiency, the most common type of CAH. I have a disclosure. At the NIH, we have a natural history study which began in 2006. It is the largest cohort in the U.S. at any one center. This slide I'm continually updating, and it's always a bit of a surprise. Last time the population was half pediatric and half adult, but my patients are aging with me, and now many of our pediatric patients are young adults. So we actually have more adult patients than pediatric. This is the age of the last visit. We see all ages, from newborns to some of the first patients ever diagnosed with CAH who are now in their 70s. We provide clinical care, but also do research. Our overall goals are comprehensive clinical and genetic evaluations. We've done research in advancing genetics as well as understanding the clinical manifestations of CAH. We refer patients to treatment studies, and of course, we're a teaching institution. The data I'm presenting today is based on this population of patients. CAH is a disease of multiple hormonal imbalances. A block in the 21-hydroxylase enzyme produces a characteristic pattern of hormone deficiencies. Impaired production of aldosterone and cortisol can lead to a life-threatening, salt-wasting adrenal crisis. Because lack of cortisol production in utero, there is an abnormal development of the adrenal gland with adrenomedullary hypoplasia. And the combination of decreased cortisol and decreased epinephrine places patients at risk for hypoglycemia. This is especially important in young children. Because of lack of cortisol feedback inhibition on the pituitary, there's an increase in ACTH and increase in androgens because there's no block in the androgen pathway. And the high androgens, the effects range from atypical genitalia due to in utero exposure to high androgens, abnormal puberty in children, and both sexes can suffer from infertility. So the overarching goals in the management of CAH are to replace deficient hormones and control adrenal androgens. There's a wide range of clinical severity, traditionally defined as two major groups: the classic form or severe form and the non-classic or mild form. In general, there's good genotype-phenotype correlation, meaning that the type of mutation the patient has can accurately predict the level of clinical severity. However, this is not always the case. There's a continuum. And Shown here, some mutations fall in between these categories, and the focus today is the classic or severe form, which is a rare orphan disease with an incidence worldwide of about 1 in 15,000, and the non-classic or mild form is much more common with less severe impairment and mild hormonal imbalances. Well, the clinical management of CAH is a difficult balancing act between too much androgen and too much cortisol. Both are undesirable states. Too much adrenal androgen results in virilization, and to control this, we often need to give too much cortisol, which leads to iatrogenic Cushing syndrome. A very important consideration during childhood is growth and development. And note that short stature is on both sides of this balance. Excess androgens as well as excess cortisol can impact growth, and likely patients experience combinations of these two states. Overall, the adverse outcomes in CAH are due to a combination of disease-related and treatment-related effects. Another unresolved issue is how best to treat. In children, there is consensus that short-acting hydrocortisone is best and is best given 3 times a day because longer-acting glucocorticoids have more growth-suppressive effects. But in adults, there is no standardized approach. So why do children with CAH have short stature as adults? It's multifactorial. Adrenal androgen excess advances epiphyseal bone maturation and can lead to GnRH-dependent or secondary precocious puberty. Glucocorticoids have direct adverse effect on the growth plate and impair growth. We see this in Cushing's disease in pediatric patients who are treated with high-dose steroids. Shown here is the growth chart of a patient with CAH. Due to exposure to excess adrenal sex hormones, she had early puberty and an early growth spurt. She was also overtreated with glucocorticoids, causing weight gain. She stopped growing early and wound up short due to a combination of disease-related and glucocorticoid-related effects. In a meta-analysis that was done of several studies over 1,000 patients with classic CAH, adult height was negative 1.38 standard deviation units, or approximately 9.7 centimeters of loss compared to the general population, or adjusted for midparental height or genetic potential, they lost about 7 centimeters. And this patient actually lost about twice that. So final height is influenced by many factors. In a prior meta-analysis, which was done 20 years ago, when many studies included patients who were not part of newborn screening, age at diagnosis or early detection was most important in achieving a taller adult height. Mineralocorticoid use has been associated with better height outcomes. So although the renin-angiotensin-aldosterone system is not directly under the influence of ACTH, relative volume depletion from aldosterone insufficiency serves as an additional ACTH stimulus by indirectly stimulating vasopressin, and then vasopressin acts synergistically with CRF to augment ACTH release. So mineralocorticoid is recommended for all patients with classic CAH. It does allow for better adrenal androgen control on lower glucocorticoid doses. Now, hydrocortisone doses greater than 15 to 20 milligrams per meter squared per day during infancy and during puberty correlate negatively with adult height. So these are particularly vulnerable time periods, and it's important to really try to minimize glucocorticoids during these two periods of childhood. Now, puberty is a particularly challenging time. High growth hormone and IGF-1 inhibits hepatic 11-beta-HSD type 1. This leads to alterations in cortisol kinetics and an increase in GFR, leading to increased clearance of cortisol. Physiologically, patients are growing fast, outgrowing their glucocorticoid dose, but also experiencing increased clearance of glucocorticoids. Altered lifestyle changes, such as changes in sleep-wake patterns, increasing self-management, this all results in intermittent compliance, complicating management. And often all of this leads to increasing hydrocortisone doses, but of course we just said that you shouldn't really use doses greater than 15 to 20 milligrams per meter squared per day. So puberty is particularly challenging. Now, obesity is also a challenging situation with effects on glucocorticoid metabolism. We recently showed in a longitudinal study using our natural history study that cardiovascular disease risk factors start in childhood, even before age 10. Fatty liver increases cortisol clearance. A decrease in insulin sensitivity independently increases cortisol clearance. And weight loss can improve insulin sensitivity and liver fat and reverse these processes. And we showed this in a case report of a 19-year-old obese CAH female who underwent sleeve gastrectomy. So with dramatic weight loss, her hydrocortisone dose was decreased 34%. She had changes in the cortisol kinetics and clearance, and she was much easier to manage, even though on a much lower dose of hydrocortisone. Well, height-enhancing drugs have been used. There are reports using growth hormone, but these reports are retrospective. Often growth hormone was used in combination with GnRH agonists, and historical controls were used. Personally, I've not had much success using growth hormone in CAH patients, but theoretically, since growth hormone works in non-growth hormone deficient children with short stature, it should potentially increase the growth in CAH patients who are in good control. Inhibitors of sex steroids have been used for years at the NIH starting in the 1990s, and because there is inhibition of sex steroids, and sex steroids are also synthesized in the gonads, this approach can only be used in either prepubertal children, women on oral contraceptives, or men on testosterone replacement. But this approach is appealing because it allows for glucocorticoid reduction. And at the NIH, we studied sex steroid blockade in prepubertal children. We used a combination therapy of an anti-androgen flutamide that blocks at the androgen receptor, an aromatase inhibitor that blocks the conversion of androgens to estrogens, and lower dose hydrocortisone. And following 2 years, despite being on lower dose hydrocortisone, children had normalization of their growth rate and bone maturation. We have followed patients until adult height, and the long-term outcome study should be completed very soon. Now, since that time, new drugs have been developed for the treatment of prostate cancer, and these drugs block androgens, and specifically there's a 17-hydroxylase inhibitor, abiraterone, that's been studied in CAH. In a phase 1 study done by Richard Aukus at University of Michigan, 6 adult women with classic CAH received 6 days of treatment. And you can see here that androstenedione was elevated. It was 1.5 times upper limit of normal at baseline. It normalized after 6 days of treatment and also remained low even 2 days after they stopped the therapy. So this was all very positive. Now, 17-hydroxylase inhibition leads to accumulation of the mineralocorticoid 11-deoxycorticosterone, or DOAC. And we know this from patients with 17-hydroxylase deficiency, and also in the men with prostate cancer who were treated with this, they had hypertensive. But in patients with CAH, there's a block in the pathway to DOAC production, so this shouldn't happen. And in this study, it did not happen. The patients didn't have hypertension and didn't have an elevation of DOAC. But because of the positive results, there is a multi-center phase 1-2 study of prepubertal children that's been approved. The PI is Perrin White at University of Texas. It's not yet studied because of some delays in pediatric formulation, but it should be starting soon. So the overarching management goals in CAH are to prevent long-term complications across the lifespan. For example, in children, we optimize growth and pubertal development. We try to optimize comorbidities in adults, and of course, the prevention of all these comorbidities start in childhood. But most important, we also try to prevent adrenal crisis. And this is most often triggered by infectious illness. This has been shown in multiple studies, including our own at the NIH, as well as a large retrospective study done in Germany. In a nationwide study done in Sweden, adrenal crisis was found to be the leading cause of death in patients with CAH, and in a retrospective matched cohort study in the UK, all-cause mortality rates were 5 times higher in CAH patients compared to controls. Now, the standard way in which, as endocrinologists, we prevent is by teaching patients stress dosing or sick day rules. So we instruct patients to either double or triple their dose for illnesses, surgeries, trauma. But in reality, the highest risk situation is infectious illness. And then, depending on the level of severity, we also teach them to give an intramuscular injection. And of course, medical alert identification is important. Now, at the NIH, we do have the advantage of having more time to spend with patients compared to other clinical centers, and we take this very seriously. We enforce our sick day rules, and for the adults, we teach self-injection, and we teach all the parents how to inject. So using our natural history study data, we sought to characterize stress dosing practices and outcomes in our large cohort of patients. We performed longitudinal analysis in 156 patients. 58% were male, 63% salt wasting, and they were followed on average for 10 years. We had data on stress dosing, illnesses, reason for stress dosing, ER visits, hospitalizations, and we defined an adrenal crisis as resolution of symptoms with IV fluids or parenteral solucortex. So by definition, they had to have gone to a hospital or an emergency room. So what events were associated with stress dosing? Well, shown here is our data separate for children and adults. And overall, and similar to what other centers have reported, we found that the most common reason patients stress dosed was a GI illness or an upper respiratory tract infection. And this was true no matter what the age. And the upper respiratory tract infections included things like strep throat, ear infections, flu-like symptoms, et cetera. And injury and surgery accounted for about 15% of our stress dosing. And we did find some differences between children and adults. Children had more frequent illnesses and stress dosing, but adults were more likely to go to an emergency room and be hospitalized. So we concluded that parents were better able to manage things at home than the adult patient. Adults were more likely to stress dose when contrary to our teaching, so when not indicated, and 27% of the time adults were stress dosing for mental stress or other reasons that we had not taught them to stress dose for, and this happened about 10% of the time in pediatrics. Women were more likely to go to an ER than men and also more likely to stress dose. And predictors for stress dosing were young age and being on a lower hydrocortisone dose. There were no good predictors identified for adults. So although as pediatricians we aim to minimize glucocorticoid dose to optimize growth and avoid iatrogenic Cushing syndrome, this may be at the expense of increased risk of illness episodes with possible adrenal crisis. Well, what events were associated with adrenal crisis? The most common was infectious illnesses. Similar to other reports, GI and respiratory illnesses were most important. And for children, there were a few other varied events such as urinary tract infections and significant injuries. Overall, our incidence of adrenal crisis was similar to what's been reported in other centers, and we had 11 cases of either presumed or documented hypoglycemia, and this is very important. And here are these 11 hypoglycemic events, and I'd like to point out a few important observations. Although all were children, the oldest child was 11 years old, so hypoglycemia was not restricted to very young children. In 2/3 of the cases, the stress dose of hydrocortisone was given for 1 to 4 days prior to the event, so multiple days of stress dosing with glucocorticoid did not prevent this occurrence. Decreased oral intake likely played a role. 50% of episodes occurred in the early morning, and 3 had seizures. All cases were associated with infectious illnesses. The 11-year-old had documented influenza, and 1 case, a 4.5-year-old with neurovirus, had a prolonged seizure, unfortunately leading to some permanent neurologic damage. This was a sad case. The patient and her family were traveling and they were unable to get medical help in a timely fashion. So as a result of this study, we recommended revision of sick day rules to include more frequent stress dosing at set intervals or specifically every 6 hours for all children and for adults with significant illness. So parents are instructed not to let their sick children sleep for more than 6 hours without stress dosing. We also emphasize frequent ingestion of simple and complex carbohydrates. And although the need for stress dosing with minor surgical procedures is debatable, aggressive measures should be taken for infectious illnesses, especially in young patients with salt-wasting CAH. And we also evaluated hormonal associations. So for the biomarkers, 17-hydroxyprogesterone and androstenedione, we found no association. And we weren't able to measure these at the time of the event. So these were biochemical evaluations at the prior clinic visit. But we did have associations with elevated plasma renin activity. They were more likely to have an ER visit for children, more likely to have adrenal crises. And also, since we're a research institute, we measure things not necessarily measured at other centers, and we measure epinephrine. And they were more likely to have an emergency room visit for children if they had undetectable epinephrine levels, and undetectable epinephrine was also associated with higher rates of illness episodes in adults. Well, are patients with CAH more likely to get infectious illnesses? This is unknown. A retrospective primary care database in the UK, this is a study based on drug prescriptions and clinical diagnoses. They reported an increased rate of infectious illnesses in patients with CAH, and specifically increased rates of respiratory, urinary tract, and GI illnesses, so really the same illnesses that precipitate adrenal crisis. Now, several studies have found increased risk of infections in patients with primary adrenal insufficiency due to other causes, but the problem is most of these patients have autoimmune adrenal insufficiency, so impaired immune function might be disease-related. And the question remains, does glucocorticoid regimen play a role in the rate of illnesses? Well, there is some evidence from Plenodrin studies. So Plenodrin is a modified release form of hydrocortisone, not used for CAH, but used for other forms of adrenal insufficiency, where there is circadian rhythm of cortisol in the morning and early part of the day, really not much coverage at night. But in a single-blind randomized trial, this once-daily modified release hydrocortisone had more normal immune cell profiles and less infections versus standardized glucocorticoid treatment. Now, patients with CAH are a different population, but conventional glucocorticoid therapy is not very physiologic, and it's unknown if rates of illness and subsequent rates of adrenal crisis will change with more widespread use of physiologic replacements. Now, what about COVID-19 experience in CAH? Well, what we do at the NIH is we recommend stress dosing according to symptoms. So no symptoms, no stress dosing, or mild symptoms, no stress dosing. And to date, we've had 23 CAH patients with COVID. None were immunized, although just today I found out about 2 people who are immunized who have COVID now. But for these 23, 18 were confirmed by PCR testing. 10 did not stress dose. They were mostly young adults in their 20s, and they did fine. 6 stress dosed, and the range was from 1 day to 3 weeks. We had no deaths and 2 hospitalizations. The 7-year-old also had a seizure disorder. She was hospitalized because of increasing seizures. And the 63-year-old was in the ICU for a week. She was sick for a few months. She subsequently did well. But I think our experience reflects the general population in that younger people are doing well. It's older patients that have comorbidities that are not doing as well. Well, it's an exciting time to be doing CAH research with so many new therapies in the pipeline. And at the NIH, we've studied sex hormone blockade in children and physiologic glucocorticoid replacement for years with our involvement in the early stage clinical trials of Chronocort and pump studies. With the recent licensing of Chronocort in Europe and the UK, we will continue to learn more about the benefits of circadian glucocorticoid replacement. There are 2 CRH antagonists and gene therapy currently in approved clinical trials. Oh, and abiraterone is also approved for prepubertal children. And other new therapies are in earlier phases of development. And with all of these therapies, the ability to decrease daily glucocorticoid is an important goal, and it'll also be important to study the risk of adrenal crisis. In summary, adult height is influenced by many factors. Infancy and puberty are two challenging and vulnerable time periods. Lower dose hydrocortisone is associated with increased illnesses, especially in young children, but higher glucocorticoid dose does risk growth suppression. CAH is a potentially life-threatening disease. Patients at all ages are at risk for death from adrenal crisis, which is most often triggered by infectious illnesses. Multiple hormonal imbalances play a role, including epinephrine deficiency. Prevention of hypoglycemia should be a part of adrenal insufficiency patient education or your sick day rules. New therapies promise to improve patient outcome. Pediatric studies are needed. So in conclusion, I'd like to acknowledge and thank the people who contributed to the data I presented, and thank people in my section shown here who over the past 2 years have kept our natural history study alive and our clinical research going. It's certainly been a challenging 2 years with lots of remote meetings, telehealth, rotating schedules in order to accommodate in-person patients. And I look forward to seeing everyone in person soon. Hopefully some of you at the Endocrine Society in Atlanta in June. Stay safe and healthy. Thank you.
Hello, everyone.
Can you hear me, Dr. Deborah Berg?
Yes, I can. Hello, everyone. Thank you for having me today.
No, thank you. Thank you for this great lecture. And we have some minutes for questions. Please send your question by chat.
I see that there was one question I see in the chat, which I can answer. So the question is, what is your experience in CAH patients submitted to gastrectomy regarding the fludrocortisone doses? So we have had 3 patients who had bariatric surgery. And, you know, as I mentioned in the lecture, with the dramatic weight loss, we have been able to decrease their glucocorticoid dose and get them under better control. We've not had any problems with the fludrocortisone absorption or the glucocorticoid absorption. And I think they've pretty much stayed on the same fludrocortisone doses.
Okay. And can you speak about your experience with adrenalectomy?
Yes. So we've done a few patients. We've had adrenalectomy in a few patients, and I think very positive results, although we are very cautious in who we do adrenalectomy on, because, you know, often the patients who have a lot of trouble with control and who have had very enlarged adrenal glands have a history of non-compliance. And of course, you know, you don't want to do an adrenalectomy in somebody who's going to become non-compliant at some point. So we've been very cautious about who we do adrenalectomy on. We have 2 women who we really could not control medically, not only without high doses of glucocorticoid, but also without the use of anti-androgens. We had them both on bicalutamide, and both of them wanted to get pregnant, and that's why we did adrenalectomy. And actually, they were both able to become fertile following their adrenalectomy. I've never done an adrenalectomy on a child, only adults.
Okay. What do you think about the giving a higher dose of cortisone at night to block CRH?
Yes, I know this is controversial. We we do it especially in children. In adults, they often have trouble sleeping. So, as you know, the problem in CAH is that nighttime surge of ACTH to control the androgens. And I think it works. Of course, there's metabolic consequences, or theoretically and potentially metabolic consequences to be exposing patients to the nighttime glucocorticoid. But in the children, when they're on 3 times a day hydrocortisone, I always give a dose before bedtime, that last dose. In the young adults, sometimes when they have trouble with control, we often change the nighttime dose to prednisolone or prednisone. So it works in terms of suppressing the ACTH. But this is why we've been involved in the development of new forms of glucocorticoid, and why there are studies out there, because there are metabolic consequences and it's not ideal to have that nighttime dose. Chronocort, which aims to replace glucocorticoid in a more circadian fashion. And because of the delayed release, you take it at night, and the cortisol is peaking in the morning, but it starts to rise in the middle of the night. This works well. And it's now been approved in Europe, in the UK. There's CRH antagonists that are being studied. I think that'll help in reducing the glucocorticoid dose. So it's actually a very exciting time to be involved in research for CAH. There's so many new possibilities out there that are being studied. There's an ACTH antagonist that's in an earlier phase of studies. So I think eventually, maybe 5 years from now even, we'll be treating CAH with very different medications and not need to do that high nighttime dose. Maria, you're muted. I can't hear the question.
Yes, sorry. Which is the best laboratory study to check the good control? What do you think?
The best, I'm sorry, say that again, the best?
Laboratory test.
Oh, okay. So we look at 17-hydroxyprogesterone and androstenedione, and of course the plasma renin activity also, because you don't want to forget about the salt wasting components. You want to be following that in patients. I look at the combination. I don't depend on just 17-OHP or just androstenedione. And I must say that we've started measuring 11 oxygenated androgens in all patients too, and we're currently trying to look at that in relation to the more typical biomarkers to see if that might be better.
Okay, so I don't have more time, sorry.
Okay, well, thank you. Everyone stay healthy.
Thank you very much for your attention, and we hope to meet in the future too. Thank you.
Yes, hope to be in person next time. Thank you. Bye-bye.
Thank you, Deborah. Bye.